Hi, good day. It's Peter Fairbairn back again from Ethos Regeneration Limited, Clinical Director. What we're going to look at now in this video and in these cases are slightly more complex cases. Yes, we found that Ethos seems to be an ideal regenerative material in many different areas, from periodontitis, which we'll do a video on later with the periodontist, and periimplantitis, cysts, and even we're getting a lot of really good feedback from using Ethos in zygomatic and nasalis implants, mainly to improve the hard and the soft tissue at the exit point, where the problem exists in these more complex cases. And again, you'll see a lot of that shown on Ethos case studies, as well as ethos.dental. If you look at webinars and go to Riz Saeed, Riz has been doing a lot of very exciting work with the extremely resorbed maxilla. But what I'm going to actually show you today and start off with is something that I don't actually really want to promote, but now that it's being done by a lot of people and everyone's getting successful results, and also I've been doing it now and I have 6-year follow-up and a few hundred cases. This is something that's been working well, this push-in technique. And again, as I say, it's not ideal, but it allows us in an emergency, if we can't get primary and we haven't got the bone, allows us to actually understand that we can actually use an implant with no bone to implant contact and with no primary stability, and yet achieve a very good result over a long period of time. So in this particular case, we can see that it didn't have any contact with the bone. And at 10 weeks, we raise a flap and there's new bone growing over the implant, which needs to be removed by a round burr. Again, this is quite impressive. And so we're just showing how these materials upregulate host healing. And at 11 weeks, we got 77 on Ostel, which is amazing because there was no primary stability. The implant was pushed in 11 weeks before. And the benefits of this is it retains both the hard and the soft tissue. As I say, this case is loaded for 5 years now, and it's been very, very stable. And again, when we look through the x-rays, we can see the benefit of these materials by just placing the implant into the graft material with actually no bone to implant contact. Again, this is not what we taught, so I'm not suggesting to do this as a protocol to set out. I'm suggesting this can be done in an emergency situation. With the case loaded 5 years now and very stable, and I have a 6-year loaded cases as well, and with a couple of hundred, I see that there's real benefits. Yes, as you'll see on Ethos case studies, a number of other people are doing this. Ludwig just recently got in Gothenburg. I know in Sweden this would be heresy, but he had a case which was literally swimming in the Ethos, and at 10 weeks or 12 weeks he had 81 on Ostal, and the site was completely covered with new bones. So there seems to be potential, but again, it's more about materials and about how the materials upregulate the host healing. So the next area we will be talking about is the treatment of and the enucleation of cysts and grafting with Ethos. Now this is an interesting area, and it's something which I've been doing for a long time, and we've also got some really interesting cases again on Ethos case studies. And we have a case where the big cyst was basically around the inferior alveolar nerve, and the dentist, the maxillofacial surgeon, had no problem and no long side effects with paresthesia. So it seems to be very biologically tolerated as well. The case I'm going to show you is by Minas Levensis, and he did this in Athens using 7 cc's of Ethos, and it's a big cyst in the maxilla. This big cyst was then enucleated, and you can see in the photographs, the site was cleaned well, and then merely grafted with the 7 cc's of Ethos. There it is there, sutured closed. There's the cyst on the histology. And when we look at it 2 years later, what we can notice is the return of the morphology and a nice new buccal plate and a nice new bony environment. But again, if you look at the pictures, you can see how that dramatic cyst is completely turned over to host bone. When we look at it and we see a slightly more dense bone, it's not residual graft material. What we found in our research is that there's a reduced connective tissue component in the new host regenerated bone. So often we basically have a slightly dense, it looks like there's material there, but it's not. It's actually bone fully turned over. There's hundreds of research papers all stating the same thing, is that beta-2C fully turns over to host bone in the long run. So it's an important aspect to look at this as just another field, and these are just more complex areas of using Ethos. And what we will move on to next is another area that again takes a bit of practice and expectation, and that's tunnel grafting. So we've been doing tunnel grafting for about 10 years, 11 years, so not very long. But what's happened really is Ethos has allowed us a little more progress on materials. And this has been the exciting thing, is it just gives us another bow in our, another arrow for our bow. And so the idea of having to, especially on the lower and on the posterior mandible, this is the area we use tunnel grafting most often, but you can use it in any areas. You can use it in the aesthetic zone, and all it does is means you're making a very small incision, lifting the periosteum, placing the Ethos, closing that small incision again. It's as simple as that. There's no holes, no decortication. I often get asked about that, especially on the mandible. Do you decorticate? Do you drill holes? No, and all the research shows that it doesn't make any difference. It's just something that we do out of habit, really, I guess. And from, tails passed down, you've got to decorticate the bone. No, you don't seem to need to be able to do that. And I'll say that's backed up with the research. So the case I'll be showing with tunnel grafting is my receptionist, and she had an implant done on the opposite side, and here we were going to do a lower left 6. She had the lower right 6, and she had a block graft done, and it was pretty traumatic, and the results were not as great as they could have been, and so she was reluctant to have another implant. So I said, look, we can do this merely with tunneling. So we just made a small incision. Now, she was lacking in keratinized tissue, so we made a small incision distal to the 5, or at the level at the back of the 5, and just lifted the tissue. Often I'm asked about how do we actually place the graft into the site. I use an amalgam carrier, amalgam gun, and basically it allows us to, through that small incision, place the amalgam gun at the deepest side, draw it back, and placing graft material as you're drawing it back, then reload the gun, put it in, draw it back. But the concept is we're not going to get 5 millimeters vertical, 5 millimeters horizontal. So what we do is we do a small amount, and once this is turned to bone at 10 weeks or so, we make a small incision, and then we place the implant with further grafting then. So it's like a 2-stage approach, and that's what we did here. So as you can see on the x-rays, there's just a small amount of new host regenerated bone. As the material is turned over, we make a vertical incision, place the implant. Here it was a Dio implant 3.5 by 10, and just grafted a little more Ethos down around the site and sutured it closed. In a further 10 weeks, we can now see we have a nice volume, and we also have nice keratinized attached tissue, and I've done no free gingival grafting here. When we looked at it on Ostel, we had 75 on the Ostel meter, so it was new, it was very good and very stable. And then loaded it, and here it is loaded 2 years. It's been loaded 4 years now. I need to get a new photograph considering she's just sitting downstairs. But when we look at the x-rays at placement, you can see, and loaded 2 years, you can see the density of the bone even in a PA without resorting to a CBCT. And when you look at the clinical photograph, you can see we've got a nice cuff of keratinized tissue, but higher up you can see where the mucosal tissue is. You can see the thickness from what we had before. So this has been a great case, and it's been loaded 4 years, and it's helped to do something more minimally and with less pain and less surgery. Yes, we have a number of other cases using tunneling, including on the upper. And again, I think some of them these are on Ethos case studies. And I think we've got one on ethos.dental as well, if you look at the cases. So there's so many different things, and it's only once you start getting used to it, you then start pushing the boundaries of what you can use it in what cases, in how far you want to take it. There will be another video case done by Michael Ainsworth on using a suture technique as a tenting technique, and we've been seeing some very good results with this, so that we don't need a secondary surgery to remove the tent. So thank you very much for attending this video, and we will be looking forward to seeing you again for the next video involving other dentists. Thank you very much.